Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Cardiac Structure Injury After Breast Cancer Radiotherapy, Cross-Sectional Study with Individual Patient Data by Taylor et al. My name is David Wazer, and I am Professor of Radiation Oncology at the Alpert Medical School of Brown University in Providence, Rhode Island, in the United States of America. My oncologic specialty is radiation oncology with a focus in the management of breast cancer. Radiotherapy is a critical part of breast conservation therapy for early-stage breast cancer, and the addition of radiotherapy to breast-conserving surgery reduces breast cancer-specific death compared to breast-conserving surgery alone. Moreover, post-mastectomy radiotherapy reduces breast cancer mortality in women with positive axillary lymph nodes. However, radiotherapy delivered to the breast after breast-conserving surgery or to the chest wall after mastectomy has long been known to be associated with cardiotoxicity and an increase in cardiovascular morbidity and mortality. Despite this knowledge, radiation oncologists have struggled for many years with some very basic questions. What is the mechanism of radiation-induced heart disease? What dose of radiation to what part of the heart actually causes toxicity? Are there doses that are safe for the heart? What is the most meaningful parameter to guide treatment planning? Some of these questions were addressed by a landmark publication that appeared in the New England Journal of Medicine in 2013, which was authored by the same group responsible for the current work being discussed in this podcast. The 2013 publication consisted of a population-based case control study of more than 2,000 subjects treated with radiotherapy for breast cancer in Sweden and Denmark from 1958 to 2001 that compared women with major coronary events to controls. A major event was defined as myocardial infarction, coronary revascularization, or death from ischemic heart disease. As nearly all patients in the cohort were irradiated prior to the advent of three-dimensional treatment planning, the mean radiation dose to the heart and to the left anterior descending coronary artery could not be measured directly and were estimated for each patient using an idealized typical anatomy. Analysis revealed the mean dose to the heart rather than coronary artery dose was the better predictor of major coronary events. Women with pre-existing cardiac risk factors, including history of other circulatory diseases, diabetes, COPD, smoking history, or a high body mass index, were found to have an increased risk of cardiac events related to radiotherapy than other women. There were three particularly noteworthy findings in the 2013 paper that have influenced clinical practice. First, cardiac events increased linearly with the mean dose to the heart beginning within the first 5 years after radiotherapy and continuing thereafter. Second, there was no identifiable threshold dose below which there was no association with cardiac events. Third, the establishment of the mean heart dose as a useful variable to guide breast cancer radiation treatment planning and delivery. However, the question of what part or parts of the heart were particularly relevant to radiation toxicity remained unanswered. The current paper is an extension of the prior analysis and attempts to address this latter point. These authors now examine a 456-patient subset of the original cohort. Again, the women included in the analysis received breast cancer radiotherapy during the period from 1958 until 2001, with most receiving radiation therapy before 1990, and later experienced a major coronary event. For 414 women with documented location of left ventricular injury, the doses to 5 left ventricular segments were not measured, but estimated, using basically the same virtually reconstructed typical anatomy as described in the 2013 New England Journal of Medicine paper. A further analysis was performed on a subset of 133 women who had documented location of coronary artery disease defined as greater than or equal to 70% stenosis. In this cohort, the doses to 6 coronary artery segments were also estimated. For the analysis, the study authors employed a commonly used technique that compared the numbers of women with heart disease following radiotherapy for left-sided and right-sided breast cancer to provide insight into the effect of radiotherapy on individual segments of the left ventricle and coronary arteries. They demonstrated that for segments where there was little difference in the typical dose received from radiotherapy for left-sided and right-sided breast cancer, the left versus right ratios of the numbers of women with injury were close to 1. However, as the differences in typical segment dose between left-sided and right-sided cancer increased, so did the left versus right ratios of the numbers of women with injury to the segment concerned. Most increases in the rates of injury were statistically significant when the left minus right difference in radiation dose was more than approximately 4 gray. Radiation-related increases in injury were seen in every studied cardiac structure, including the lateral, septal, anterior, and apical left ventricular segments, the proximal right coronary artery segment, and the proximal and mid-distal left anterior descending coronary artery segments. These findings strongly suggest a close and direct relationship between radiation exposure and injury to different segments of the left ventricle and coronary arteries. They further suggest that all segments of the heart are sensitive to radiation and that doses to all should be minimized. The primary methodological critique of this study is the same that was directed at the earlier paper. That is, individual patient CT information was unavailable because the women were irradiated before the era of 3-dimensional CT radiotherapy planning. As such, cardiac structure doses were retrospectively estimated using a typical CT scan. However, this concern has been mitigated somewhat by published data from these authors and other independent investigators that would suggest that the findings of this estimating technique are reasonably accurate and reproducible. Another concern is the historical nature of the data, in which most patients were treated with techniques and radiation doses that are not reflective of contemporary practice. Lastly, the potential interplay of variables such as the presence of pre-existing coronary arterial disease as a determinant or modifier of left ventricular dysfunction may be confounding elements in the analysis. Do these findings have implications for the current practice of breast cancer radiation therapy? Cardiac radiation doses have been dramatically reduced over recent years and are typically far lower than those observed during the period of which were collected for this study. In fact, several large contemporary data sets have failed to demonstrate a significant increase in cardiac morbidity or mortality with modern breast radiotherapy, suggesting that perhaps radiation-induced cardiac injury is no longer a concern in the computed tomography-based era whereby clinicians are proactively minimizing the dose to the heart. However, radiation oncologists will readily admit that heart sparing is more easily achieved in some than in others, as many women have unfavorable anatomy that makes incidental irradiation of the left ventricle and coronary arteries unavoidable. The data of the study by Taylor et al. Underscored that irradiating these structures causes injury in a dose-dependent fashion, and that, where possible, every effort should be made to exclude them from fields using cardiac-sparing techniques. In breast cancer radiotherapy, cardiac exposure may increase in the future, as recent studies have shown that internal mammary radiotherapy improves breast cancer survival, and it is difficult to irradiate the internal mammary chain without incidentally irradiating the heart. As a general matter of irradiation for all cancers located in or around the thorax, there is a lack of consistency in radiotherapy guidelines on which cardiac structures are sensitive to radiation and should therefore be avoided. This paper has demonstrated associations between radiation dose and injury for left ventricular and coronary artery segments. Therefore, the safest strategy based on current knowledge is to minimize dose to all segments. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.